setup. Let's hope that that works as well. I'm not really sure with this connection, but let's see. Hope for the best. Right. So this is the outline of my talk. I'll talk about two cases. One which is a common cause of hemoptysis. Then I'll go through some MCQs and chest x-rays so that it won't be so boring for you. And then I'll talk about a rare but important cause of hemoptysis. And then present a conclusion slide. So let's start with a patient. And this is a 65-year-old man who has been coughing up small amounts of blood for the last 10 days. And he has actually coughed out half a cup on the day prior to admission. On admission, he coughed out, that is in the ETU, he had coughed out about 200 ml of bright red blood. So what is the cause? Right? Any ideas of possible causes? Yes. You all need to participate, otherwise it's very boring. I couldn't get the Clinmark auditorium today. That's why I'm doing a Zoom class. So, any ideas? Yes?
Tuberculosis, madam.
I'm sorry? I couldn't hear you.
This be tuberculosis, madam.
Okay, so when we are thinking of the causes, let's think in broad categories. Good thought, most likely correct. The commonest cause of hemoptysis is from the respiratory tract, and that is blood coming from the tracheobronchial tree, usually from the lower bronchial tract. But sometimes it could be blood which was vomited up into the respiratory tract from the GIT, or it could actually be epistaxis, which is blood dripping down from the nasal cavities, which was coughed out. So always consider, first of all, is it actually hemoptysis? Then you need to think, is it a local problem? Because usually if there is hemoptysis, there is bleeding from a local cause in the respiratory tree. So first think, is it a local problem, or is it then part of a generalized bleeding disorder? So this is your first step in your thought when this patient comes, is to figure out whether this is actually blood which is being coughed up from the respiratory tract. So the lung is very vulnerable to hemoptysis because there is a dual blood supply, and there is a low pressure venous system which is very extensive, and a high pressure arterial system. So the venous system contains a large pool of blood, and if there is hemoptysis, you have potential for a very large amount of blood to be lost. So coming back to our patient, yes, you were right. He had pulmonary tuberculosis. He had pulmonary tuberculosis in 2017. He had taken his anti-TB regimen for the full complement of time, 6 months. But now he has had a mild cough and has felt unwell and has a slight weight loss since 2021. He was hospitalized in 2022 after a road traffic accident. And so now this is June, this is April 2022. He has never had a fever or hemoptysis before this episode, and he has not had any rash, liver disease, kidney disease, hematuria, or an increased bleeding tendency. Okay? So can someone tell me what kind of causes I have excluded with this statement? Yes? Anyone? Why did we mention about rashes, liver disease, and hemoptysis? Is my voice still breaking up, Chaman? Still breaking up?
I can hear you, madam. I'm not sure about the others.
Okay. So hopefully it's not me then. Okay. Right. So why would anyone talk about a rash, liver disease, kidney disease? Anybody? Can we participate because it's very boring otherwise? Yes?
To exclude.
Okay, rashes could be due to autoimmune diseases. Of course, it could still be a rash due to a bleeding tendency. The other thing you were telling me, what were you saying?
To exclude a generalized bleeding disorder.
Yeah, of course. And what about liver disease? Same thing, really, to exclude a generalized disorder. What about hematuria and renal disease? Anyone? We'll come to that. That's okay.
Like good pastures, hemoptysis and hematuria.
Absolutely, like a pulmonary renal syndrome. So our gentleman, he smoked 1 pack a day for 20 years and quit 5 years back. And he's not on any anticoagulation or non-steroidal anti-inflammatory drugs. On examination, he was in distress. He was coughing out small amounts of blood, and he had features of a very rapid heart rate, a high blood pressure, relatively systolic, and a fairly rapid respiratory rate. He was maintaining a saturation of 90% on a high flow mask. Okay, so do you think that he's well compensated, or that he has any other problem? What is your assessment of his state?
Hemodynamically stable, madam.
He is stable. What do you think? That's Dushanti, right? I recognize your voice. Do you think is he just compensated, or is he really stable? What do you think? Can he get really bad suddenly?
Yes, he can, because his saturation is also still 90 on 100% oxygen.
Yes. So the problem is not sorted really. He's breathing very fast, his saturation is low, and he's having a very high heart rate, and his blood pressure is maintained probably by this sympathetic stimulation, but all of this can crash very quickly, right? So he's cold in his peripheries but not sinus. There is no bruising on the skin. There are crackles in his upper zone, that is coarse crepitations, but there are scattered wheezes, and there is no organomegaly. So what is the immediate danger? The immediate danger is that he has had a massive haemoptysis. And if you would have seen, those of you who are in the ward, that massive haemoptysis is usually followed by more massive haemoptysis. So it is a very dangerous condition to watch. And also this blood can flood the tracheobronchial tree. So the patient cannot participate in air exchange because the blood is flooding into the airways, and the patient won't be able to breathe. So he's losing blood and he's not able to breathe. So this is a very, very poor prognosis if there is a massive haemoptysis. So there are many things that we need to do. First, we have to ensure that he gets enough ventilation. So we have to keep his oxygen going. We have to keep his breathing going. We have to protect the airway which is unaffected. So if I'm coughing out blood from my right lung, I have to make sure that I don't push blood into my left lung, because my left lung can cope for a period of time. And also we need to maintain hemodynamic stability. So what do? You position this patient lateral decubitus. with the bleeding side down. So there is a feeling of compression on that side, and also it allows the good lung to ventilate, right? You need to give volume replacement with crystalloids and if necessary with blood. And you might need to do selective intubation to protect the airways and to keep the respiration going. But these are thoughts for seniors to do, but you really need to think about all of these. So here is your first Zoom poll. Let's see if this works, okay? I'm going to try this one. So let's launch the poll and see if it works. Okay, can you see my poll? Yeah? Not really?
Can see, madam.
Can see. Okay? Right. So can you vote? What would you do next to find the cause? Anyone voting at all? Does no one want to do a chest X-ray? In this patient, what is the most likely problem? Anyone? This is actually a best of 5 question. I have unfortunately put 6 responses. Anyone? Yeah. Can you see your poll?
Madam, there are 5 questions in the poll, madam.
And we have to answer all of them to submit.
Oh dear. Is it? Okay. So that's not going to work. Let me end that. The poll was supposed to be serial. Is that why it's not happening? I have 5 questions. Never mind. We'll do with this one. So which one would you do next? Yeah. Which is the most important test to do next?
A chest X-ray, madam?
Absolutely. I think a chest X-ray is very important. You need to do the full blood count and the CRP just to make sure how your parameters are doing. And you might need to do a sputum, AFB, and malignant cells, but that will take time. And your immediate cause would better be got from the chest X-ray. So because this is a single best response, it is best if you do the chest X-ray next, because all the other tests, though some of them are useful, they will take time, and your next most appropriate test is the chest X-ray, because it will give you the causes of what is going on. Okay? So I'll let you all vote in, but still you can continue to vote, and we will continue to vote at all the polls, and then we will see. This is my first venture with the Zoom poll, and it is right. Okay. So the causes of haemoptysis. Any questions there? Any questions there?
Madam, in the previous slide, before the question, you have mentioned selective intubation. Can you explain that? What you meant by selective intubation?
Because sometimes you can selectively intubate that bronchus rather than further up. That's what I'm trying to say. You understood?
Yes, madam.
Yeah, you can exclusively put a tube into that to keep that pattern. That's what is meant by selective. Okay? People keep
madam.
on answering the poll. I'm very upset. Only one person has answered. Apparently, I don't know. Is it one person has answered all? Okay, right. So what are the causes of haemoptysis? And Professor Sham has uploaded some material to the LMS, but in my brain, there are 4 big categories of haemoptysis. Okay, causes of hemoptysis. The first commonest cause is infection. So we have tuberculosis, bronchiectasis, lots of unusual infections also. But the commonest ones are just the standard respiratory tract infections. And with the infections, there's inflammation, which can erode into the blood vessels. Similarly, in tuberculosis, there can be granulomatous inflammation, which is eroding into a blood vessel. So infections are a very common cause. Vascular disease is also common. You can get pulmonary embolisms with infarcts, which cause hemoptysis. That's a rare cause of hemoptysis. It rarely causes hemoptysis, but it can. Of course, you can get pulmonary arteriovenous malformations. You can have diffuse alveolar hemorrhages due to vasculitis, cocaine, and all the pulmonary renal syndromes you mentioned. You can have hemoptysis due to malignancies, bronchial carcinomas, so or even metastasis, and other mechanical causes of damage to the lungs can also cause hemoptysis. So if you see a patient with hemoptysis, first think of these four groups and see if there is anything which any causes which you might be able to identify, right? So next question, and you can answer that one as well. So what are the possible causes of hemoptysis in this patient? Ladies and gentlemen, can you click away, please? Yes. Anyone? Is it working, the poll? Can you see it?
No, madam, we can't see.
Now?
No, madam, not yet.
We can't see. Okay. Now can you see it?
Yes, madam, now we can see.
Okay. And is the Zoom poll option working for you? Do you need more time? Okay. Why is pulmonary tuberculosis reactivation likely? Most of you thought it was possible. Anyone? Yes?
Yes, a significant past history of pulmonary tuberculosis, madam.
Absolutely. Reactivation is always possible. What about why did less people choose post-primary tuberculosis with superadded infection? Anyone who thought it was less likely? This is a discussion. It's not a yes-no kind of, it's not an exam. So you can answer what you like. Yes? Anyone who thought it was likely, not likely? Lung cancer? Anyone? Lung cancer is always possible in a smoker. Bronchiectasis in a tuberculosis lung, always possible. A mycetoma in a bronchiectatic tuberculosis lung is also possible. Pulmonary embolism and pulmonary vasculitis are less likely with this history, but I would have also marked post-primary tuberculosis with a superadded infection, because when you have a damaged lung, and you can expect that there would be poorer defense mechanisms, less mucociliary clearance, more accumulation of secretions, and therefore you can have more more infections in that lung. Okay, so that's our first, that's our thought. So we'll end the poll and move on. So these are the investigations in this patient. The hemoglobin is 11. The white cell count is high. The platelet count is also slightly high. And the CRP is also high. The liver function, renal function, coagulation profile is normal. And this is the patient's X-ray. Anybody?
There's a cavitating lesion in the upper apical zone of the chest X-ray.
Absolutely. So there is a slight loss of lung volume in the right upper lung in general, and this is more marked in the right upper zone, and you can actually see a well circumscribed lung cavity which is there. So there are certain possibilities, and this is a close-up. So depending on the possible cause, and in this we are thinking of a cavitating lesion, maybe a lung abscess, maybe a post-tuberculous cavity, which is superadded infection, maybe it is a post-tuberculous cavity with a mycetoma. Always we have to consider the possibility that it is also a cavitating neoplasm, but that it becomes less likely in this condition. So we have to consider further imaging to make this, to further make sure that we get the cause. We'll also have to do gram stain of the sputum, do the sputum for acid pass bacilli. Nowadays we do the spot test. We can do TB and bacterial cultures and fungus studies. If we really thought that it was a cavitating type of vasculitis, like granulomatosis with polyangiitis or vagueness, we might need to do anti-neutrophil cytoplasmic antibodies. But in this patient, given the history, I think the first two categories are the most likely. So this is a CT scan of a lung cavity, and you can see the nice lesion with a rim which is slightly irregular and a slight fluid level. This is another lung cavity. Here it's more solid with a breakdown in the cavity. And this is another CT scan with a cavity with a fluid level. Okay. This CT scan with the lung abscess. Yeah, Jayanga, you have a question.
Madam, in a cavity, madam, is it must to have a fluid level to call it abscess?
No, it is not a must. But if you have a air fluid level, then it's easier to think of it as an abscess. So if you have an air fluid level, that means there is some kind of an exudate forming. So that is why you have an air fluid level. The absence of an air fluid level does not say that there is no abscess, but if it is there, it is more likely. Have I answered your question, Jayanga?
Yes, madam. Thank you.
Okay, so you can see a cavity with an intracavitatory body like this. And sometimes you might actually in this kind of patient see bronchiectasis, and you can see saccular areas where the terminal bronchi are irreversibly damaged, and these areas also can be seen in a tuberculous lung. And then these can also get infected, and this is to show you this in greater detail. This showed dilated bronchi and bronchioles in a patient with extensive predominantly unilateral bronchiectasis. If we thought that this was a lung cancer, we might see this solid lesion with irregular margins on the CT. So this is the importance of doing the CT scan. Sometimes you might see an intrabronchial adenoma, and you can see here, can you see the line, the green arrow, and the well circumscribed lesion, which is an adenoma. Can people see? Yeah. So the other investigations really depend on the cause. In certain conditions, you might need to do a bronchoscopy. In our practice, it is usually to do the non-invasive investigations first and to do the invasive investigations later. So we generally tend to do the CT, and that gives better information for the respiratory physicians as well, because they know which areas of the bronchus to concentrate. If this patient actually had a malignancy, you might see when on the bronchoscopy this irregular friable area which is very prone to bleeding when the tube goes in. Whereas the bronchial adenoma is a discrete lesion with a circumscribed margin, which seems very uniform in its structure. So we've gone through some of the causes and investigations we want to do. If we are really considering a vascular cause and not an infective or a neoplastic cause, we would need to do a CT pulmonary angiogram or a bronchial arteriogram, right? The CT pulmonary angiograms are what are done now. Many years later, the arteriograms were done. The CT PA gives us a chance to look at the lungs as well as the arteries. So this is a CT PA which shows filling defects in a patient with pulmonary embolism. Am I going too fast? Am I going too fast? Okay. Speed is okay?
Yes, madam.
Okay, fine. Let's move on. So this is a pulmonary angiogram, which is showing an AV malformation. And this is actually an AV malformation which is seen on the chest X-ray. You can see the irregular lesion in the left hemithorax. Usually, one rarely sees AV malformation on a chest X-ray. I myself have not seen, but Professor Sham is a respiratory physician, so he has shared this image with us. So in the case of this patient, The final diagnosis based on the chest X-ray was a right upper lobe tuberculous cavity. We did the genetics, we did the sputum AFPs, we did the TB cultures, we did the bacterial cultures, the TB cultures, and were all negative, but there was a superadded bacterial infection, and that was documented on the sputum culture as well as on the gram stain. So the final diagnosis cavity with superadded infection. Are there any questions about that? Any questions?
Madam, in a post-primary tuberculosis, is there an active infection?
Well, I didn't follow your question. Sorry.
Madam, in the post-primary tuberculosis, is there an active infection?
By definition, yes. You are saying that there is a superadded tuberculosis infection. So you can have reactivation, or you can have a drug-resistant strain of the tuberculous bacilli. Did I answer your question?
Okay, madam. Thank you.
Yeah. So how do you manage? Treat the infection with an appropriate antibiotic, and we tend to combine antibiotics like coamoxiclav with an anaerobic organism if we suspect an abscess or there is bronchiectasis with superadded infection. If there is haemoptysis, there is a place for tranexamic acid, which is an antifibrinolytic. It is commonly practiced in the ward, but may not be really very effective. But if the patient has troublesome recurrent bleeding, we might need to do bronchial artery embolism by the interventional radiologist to block off and embolize the culprit artery. Some patients have even had a local resection of that area of the lung. So in general, you need to resuscitate if there is massive haemoptysis. And like I've told my students, there is no point making diagnoses in dead patients. You need to identify the cause and treat it. And you must, if you can't treat the cause quickly enough, you might need to use special methods to arrest the bleeding. Okay? Are there any questions? And we have a little break with some MCQs and chest X-rays before we go to the next case. Are there any questions? Happy to answer. May I proceed, batch rep?
Okay.
madam.
If there are questions, I'm happy to answer. Raise your hands. Okay. Let's move on to the chest X-rays. The theme is haemoptysis. So this is an MCQ. There is a 60-year-old man who presents with haemoptysis. He's restless. He has a rapid pulse rate and a blood pressure of 170/90, a respiratory rate of 20 breaths per minute, and a low saturation. And the right lung has rhonchi, and the left lung is clear. And the chest X-ray was done a few months ago, and it shows a right upper lobe fibrosis with a cavity. Okay? Shall I give you a few seconds to look at it? Yeah. People have already answered that. Oh. Any questions? Can I proceed?
Okay.
So here's the poll, and I'm going to reset it so that you can answer it. The stems are here also. So let me pull that up and do clear. Oops. So can you see this poll? Yeah. So what does he need? There are multiple answers here. So does this patient need an immediate blood transfusion? Shall we give him oxygen? Shall we get him to lie flat on the left lateral position? Shall we intubate him? Shall we do a bronchoscopy? This is the immediate treatment. And I have changed statement number 2 to give oxygen to maintain saturations more than 93 to 94%. I changed it after I made the poll. Yeah. So please
Madam,
answer.
we can't see the poll yet.
Oh. Can you see it now?
Not yet, madam.
Okay. How about now?
Now we can see it.
Okay. Ignore the top bit. Don't answer question number 4. So do you think he needs an immediate blood transfusion? Anybody? Anyone? Do you think he needs an immediate blood transfusion? Yes, no?
No, madam.
I don't think he needs an immediate blood transfusion. He's still managing well, so we can possibly manage him with crystalloids. But if he continues to bleed, we'll have to give him a blood transfusion. So that one is false. He will definitely benefit from giving oxygen. The Zoom poll has a slightly different answer from what I gave. He will benefit. He should get oxygen, whatever percentage, to maintain his saturation somewhere at least 94, 95. Should we lie him on the left lateral position, anybody? Yeah. Anyone? His problem is in the right lung. What will happen if he lies on the left lung with the right lung on top and he's bleeding in his right lung?
That will accumulate into the left lung?
Yeah, so that answer is also false. He does not need immediate intubation and respiratory support. We can do it if he doesn't, if he fails to maintain the saturation, and we really don't know whether a bronchoscopy is needed yet until we do the further investigation. So you're clear with that. Can we move on to the next question? Are there any questions you want to ask me about that? Yeah. Anyone? These were the stems you pulled on. Any questions? Any hands up? I can't see. Any questions? All clear on the responses? Please ask. I'm happy to answer questions.
Madam, how do you decide whether he needs an immediate blood transfusion?
That depends. I have not very cunningly left out that he's pale. So if he's very pale, he might need a blood transfusion. Generally, we give crystalloids, maintain the circulation. If the patient continues to bleed, we give a blood transfusion. But when this man is coming and is in the ward, while we are setting up the crystalloids, we will do a DT for cross-match for blood. Did I answer your question? We maintain his circulation till we get the blood, and sometimes we may not be need to give the blood if his hemoptysis stops and he maintains his hemoglobin. You understood? We'll have blood ready, but we may not need to give it. Did I answer your question?
Yes, madam.
Okay. Any more questions? Okay, so let's continue with the next one. This is a chest X-ray of a patient with recurrent hemoptysis. Describe the radiological appearance and what is the most likely diagnosis. Yeah. Yes, someone please answer. Anyone likes to comment? A nice X-ray where you will surely score marks if you get this for your ski. Yeah? Can someone say? Yes? Shall I? Yes, please.
Cavitating lesion in his right lungs upper zone, madam, and it has a circular shadow within it. I think it's an aspergilloma following tuberculosis.
Yeah, so very nice answer. Good. There is a thin-walled cavity with a halo of air above, and there is a solid region. So it could be a mycetoma which has colonized a tuberculous cavity. Absolutely correct. I think that is a diagnosis. Also look at the rest of the lung and compare it with the other lung and check whether the rest of the lung is having more fibrotic changes, whether there is areas of calcification which might indicate that that lung had tuberculosis earlier. Good. Next one. The following are recognized causes of hemoptysis. We don't have a poll here, I think, but I will let you answer. Let's see if I have a poll. Anybody wants to start answering?
Madam, we can't see the pool yet.
Oh, jeez. Sorry about this. Let me clear it. Shall we just answer it then?
We can't see your screen, the slide also, madam.
Can't see the slide also? Oh dear.
Yes. And madam, did you share the poll?
I did.
We can see it with the results, madam, with the previous one. So we can't submit.
Okay, give a moment.
Now it's okay, madam.
Yeah. So here we are. I need to work on my Zoom polls. Sorry. Spent quite a lot of time on it, but as you can see, not that great. So when we talk about recognized causes of haemoptysis, we are talking of causes which can cause haemoptysis without any complication. A lung abscess can cause haemoptysis without any complication. A carcinoid tumor of the lung can rarely cause haemoptysis. Idiopathic lung fibrosis on its own does not cause haemoptysis. Sarcoidosis on its own does not cause haemoptysis. But if you have chronic sarcoidosis, chronic idiopathic lung fibrosis, superadded infection can cause haemoptysis. So true, true, false, false, true. Okay. So this is another X-ray. Any questions from that? Yeah. Any questions? Can I move on if there are no questions? So,
Yes, ma'am.
yeah, this is a chest X-ray of a 60-year-old smoker who has cough and haemoptysis. Haemoptysis is for 2 weeks, cough is for 6 weeks. So, what is the abnormality on the chest X-ray? What is the most likely diagnosis? And what investigations would you do to recommend to confirm your suspicion? Yeah, please answer. Yeah, someone? We have a little more to go. I have some new things also. Yeah. What is the abnormality on the chest X-ray? Anyone likes to answer? Yeah? I'm waiting.
Left-sided middle zone heterogeneous opacification, madam.
Good. Possibilities?
I think I can see some air bronchograms, but I'm not sure. It can be a infection causing consolidation.
Yes, it's unlikely to get you, it is possible, but it's unlikely to get such a well circumscribed lesion. But your point is well taken. Any other possibilities?
Bronchial carcinoma, madam.
That is very also on the cards, and we can think of a neoplastic cause, I think, also. I actually, on my view, I can't see the air bronchogram as well, but I know what you're saying. The air bronchogram is actually superimposed on the mass. So when you're taking the chest x-ray, you're basically slicing somebody, and you see unlike in a CT, you get all the structures just compressed onto each other. So the airway, which is ahead of the lump, also gets kind of superimposed because all the structures kind of get squeezed between the plate. It's not like a CT where you slice people. Did you understand what I'm trying to tell you? Yeah. So what would you like to do to confirm your suspicion? Anyone?
CT,
Sorry?
CT chest.
CT chest. But as you very correctly said, this lesion is fairly close to the airways. So there is also, I would probably do a CT first to make sure whether there is only one mass or multiple masses, and then probably go for a bronchoscopy. Good. So third MCQ. There is a 50-year-old woman who has Haemoptysis, and she has no previous respiratory symptoms, and her chest x-ray is normal. And what are the investigations you would do to check for her cause? Whoops. Right? Can you see my slide?
Yes, madam. The answers we can see.
Okay. So I'll put it up. I hope I have a poll for you. Yeah. No poll. So what would you like to do? This is a true false. So we are talking of a person who has Haemoptysis, who has definitely having clear-cut Haemoptysis, but has the normal chest X-ray and a normal respiratory system examination. Okay, so what are the possible things you would do? Yeah, blood culture. We start from bottom up. Blood culture, anybody? Sputum for malignant cells. Sputum for acid-fast bacilli. CT scan of the chest. Endoscopic examination of the upper airways. What do you think? Sorry. Yeah. What do you think? Anybody? Would you like to do sputum for malignant cells? Yes, no?
Yes, madam.
Okay. What about acid-fast bacilli?
True.
True. What about a CT scan of the chest? It's possible for the chest X-ray to be normal and still to have lesions on the CT of the chest. So yes, CT of the chest. The other answer is quite tricky. Would you do an endoscopic examination of the upper airways? Yeah, what do you think? Would you? Personally, I would do, since there is sputum which has streaks of blood in it, and if you get her to actually cough out the sputum and there is streaks of blood in it, I would personally prefer to do the other investigations, and if they are all normal, only to do the nasal endoscopies. I don't think that there is a place for blood culture. Are you okay with that? Yeah?
Madam, regarding endoscopy, madam, can't we see whether there are any bleeding sites in the local area or in the upper airway?
You can, but as I said, we might need to face it. So this answer is a bit tricky. I think the problem is actually with the stem. So we should put which of the following investigations are initially indicated to find the diagnosis, and then the nasal endoscopy will go off. But you're right, when you say following investigations, we can consider it as true. Okay? So this is the final case. A 32-year-old patient is brought to emergency with oliguria, breathlessness, and he has a chest X-ray, which I'm going to show you. He has low saturations, a low hemoglobin, and a raised serum creatinine. His CRP and his ESR are normal. Because he's so desaturated, we are going to intubate and ventilate him. And because his renal function is so bad, we are going to do a hemodialysis. What is your clinical impression? Yes? Anyone?
A patient with end-stage renal disease having fluid.
Possible. But that is possible. Any other things?
With glomerulonephritis, with the acute kidney injury.
Possible. This is his chest X-ray. Now, what do you think?
Vaginous granulomatosis.
That's the diagnosis. What is the X-ray diagnosis? You see on that. I would say it's a pulmonary renal syndrome and that there are alveolar infiltrates. So your diagnosis becomes either a vasculitis, which has pulmonary and renal involvement, or it is an antiglomerular basement membrane disease. Okay? Difficult? Any questions? So what is the radiological appearance? I have told you. And what is it due to? And again, I mentioned what are the likely diagnoses, 2 investigations to confirm it, anti-neutrophil antibodies and anti-GBM antibodies. Okay? Any questions? final MCQ. In a patient with haemoptysis, can you see this? So, in a patient with haemoptysis, the following findings suggest a cause of haemoptysis. So, by definition, first of all, the patient has to have a cause of haemoptysis. And then there also has to be some finding which suggests the cause for that haemoptysis. Okay? Okay. Good. Everybody's getting an answer correct for this one. So we've done different types of MCQs. We did a best of 5 MCQ where we chose one investigation over the other. We did another MCQ or several MCQs which were true and false. And this is what we call an extended matching MCQ, where you match 2 parts within a single response. Okay. Are there any questions you want to ask me about how you answer these questions? I don't know if you realize that I did different types of MCQs during this presentation. Yeah. Any questions about any strategies which you would like to discuss about the different types of MCQs?
Madam, one question about that. One of the MCQs that you put earlier, madam, about the endoscopy of the upper airways, madam. In that condition, madam, if we are like you said, madam, that you might do it only if everything else is abnormal.
Yeah.
Do we have to consider that when answering the question? Or?
I think that I personally think that stem of that question should have been reworded, and that we should have put a word where it would have been easier for you to understand. If I was a medical student and this MCQ was given unchanged, I would have not marked that one response. I would have left it blank. But if someone had given it as in the immediate stage, I would have marked it false. Did I answer your question?
Yes, madam. Thank you.
Usually, all your questions are seen by at least 10 to 15 academics, especially your MCQs. So every question is looked at from different perspectives. So if there is, this is just the 2 of us, right? So still the MCQs may not be perfect. So that's so those kind of problems really will not happen. Okay. Any other things about the different types of questions that I shared with you? Any questions about the chest x-rays?
Madam, do we need to do PT-INR as a first-line investigation for these patients, madam?
It's not a first-line investigation, but I value your point because a lot of our patients, particularly people who are having tuberculosis, tend to have multiple comorbidities and therefore tend to have a tendency to have liver damage. I would do the PT-INR as part of my second-line workup. Your questions are usually worded as to what is the most likely cause, what is the next most immediate step, what is the first test you would do. You understand? So that we in practice, yes, in MCQ land, probably it won't be coming up front. Okay?
Okay, madam. Thank you, madam.
Right. So this is a rare cause of haemoptysis, but I am putting it up here because it is very critical to diagnose. This is one of my patients. Somewhere I had to put them. Right. So I was asked to do this lecture in the absence of Professor Sham because I am the person who sees haemoptysis next most. Okay. So this is a 23-year-old girl of mine, clinic. She comes with haemoptysis and pleuritic chest pain for 3 days. The problems have got worse over the last 2 days. She wanted to get pregnant, and someone has told her that she must not take any medicine during pregnancy. And despite doctors counseling her, she was lost to follow up trying to get pregnant. She has had 2 first trimester miscarriages in the last 3 years when she was lost to follow up. On examination, she is ill with a low saturation, a lowish blood pressure, and a high pulse rate. Her ECG is normal. ECG shows sinus tachycardia, but her chest X-ray is normal. Possibilities, ladies and gentlemen.
Pulmonary embolism, madam.
Yes, that would be the first thought I think of. Why do you think I put the disclaimer here? Anyone? So I put this disclaimer here because haemoptysis is not commonly seen in pulmonary embolism. But if you have a patient who comes with haemoptysis, you have to always consider pulmonary embolism. Did what I say make sense to you?
Yes, ma'am.
That's right. Okay. But it's also an important cause. Have you all talked about pulmonary embolism during your CLDs? Batch rep?
Yes, madam.
Huh?
Yes, madam. In the SOB lecture, we had a pulmonary embolism case.
Right. Okay. So then what I'm going to tell you next is quite clear. So you get an acute pulmonary embolism, which is where a blood clot or a part of it breaks off from a vein, and you get blocking of the blood vessels. And you get, because of the block in the blood vessels, the pulmonary vascular resistance becomes very high, and therefore the right ventricle is under strain, and you get right ventricular dysfunction. All of that is clear. Yes? And you were told about these different scores which predict pulmonary embolism? Yes?
No, madam.
Okay, so there are multiple scores which are used in clinical practice to predict pulmonary embolism, because pulmonary embolism, unfortunately, is not very rare. It's quite underdiagnosed. So there are many tools by which general practitioners, family physicians, or any physicians in other areas other than medicine can suspect pulmonary embolism. So there are some scores which you can use. They are not very often used in clinical practice, but this one you must have heard of. Yes? Massive, large, or low risk pulmonary embolism, or high risk or intermediate risk or low risk pulmonary embolism. Yes? Anyone? Does this make sense to you? Would the batch rep like to answer that question? Yeah. So you know that pulmonary embolism with right ventricular strain or circulatory compromise is possibly due to a massive pulmonary embolism. But you can have a situation which is called a submassive or an intermediate risk of pulmonary embolism, where there is a pulmonary embolism with right ventricular dysfunction. Then, of course, you get pulmonary embolism without right ventricular strain or hemodynamic compromise. These features are very, very important for us to figure out how to treat patients. There are various scores, but you don't need to remember any of them. All you need to remember is that if the patient's pulse rate is high, blood pressure is low, saturation is low, that you're dealing with a very complicated problem of pulmonary embolism. So you diagnose the patient based on multiple domains. You stratify the patient to high risk, and depending on that, you decide whether to treat the patients, right? So if you think that, like in this patient is hemodynamically unstable, but there are many patients in the medical wards who are hemodynamic stable. In those patients, if you think like this patient that there is a very high probability of pulmonary embolism, you need to consider a CTPA. But if there is a lesser grade of a clinical probability of a pulmonary embolism, you can use the D-dimer, which is a degradation product of cross-linked fibrin. And you can use if you can use the ELISA test, it is quite a sensitive method to identify pulmonary embolism. It is not the best, but if facilities of CTPA are low and you have a low likelihood or clinical probability of pulmonary embolism, you can do a D-dimer. If you have very severe strain with a large pulmonary embolism, the right ventricle is compromised, and then you get right ventricular dilatation. In addition, the systemic blood pressure also becomes lower, and you can get poor coronary perfusion. So this is a picture of a pulmonary angiogram and a CTPA, and this is the best method to diagnose a pulmonary embolism. We were taught of this deep S wave in lead 1, a deep Q wave in lead 3, and inverted T waves in lead 3. But in reality, you really don't see these findings very often. You just see a sinus tachycardia, a T wave change, ST segment changes. Rarely you can see a right axis deviation and a P pulmonalis. So you really need to suspect these patients up front, even without these typical ECG findings. We used to do a lot of VQ scans, ventilation perfusion scans, but they are really quite expensive, and they don't they are not conclusive in the majority. And unlike the CTPA, which can give us clues to an alternate diagnosis, the VQ scan is not very, very useful. But in a patient like mine, if there is hemodynamic instability, you need to do a transthoracic echo to assess for right ventricular dysfunction. And if you get an echo where the right ventricle to left ventricular ratio is more than 0.9, then you know that there is most likely a pulmonary embolism. You should then do a CTPA to confirm it and start the patient on treatment. So you need to give hemodynamic support, and you need to maintain the mean arterial pressure. You also need to discuss with your seniors about fluid expansion as well. Were you taught about the chest X-ray findings in pulmonary embolism? Anyone? Yes? No?
No, madam. No.
Yeah. So when we were medical students, we were expected to know this. And the main reason that you were not really taught is that they are not very often seen, but they are a legion in radiography. And I'll go through some of the signs. I just wanted to go through these things with you. So this is what is called a knuckle sign. You get a dilated central pulmonary artery with an abrupt cutoff. And if you see a dilated right descending pulmonary artery with an abrupt cutoff, you can call it, it's actually named after Chang. There's Chang sign. You can see an enlarged right descending pulmonary artery, and that also has an eponym of Thalas sign. You can see a wedge-shaped pleural-based infiltrate, and that was what was there in your extended matching question. And you can see that here. And you can see a large wedge-shaped infarct here. Or you can see these little curvilinear lines going from the pleural, going towards the pleural space, which are called Fleischner's signs. If you see focal oligemia, that is, you see in between these two arrows, that there are no pulmonary markings, and you see an enlarged pulmonary artery, this is a very useful way to consider a pulmonary embolism. So how do you manage? All patients with acute pulmonary embolism are anticoagulated. If there is hemodynamic instability and they are considered very high risk, there is a place for a reperfusion. If they don't have very high risk of hemodynamic instability and their right ventricular dysfunction is minimal, we can manage them with anticoagulation. So these are some of the reperfusion techniques which are used. RTPA can be used, and all patients with pulmonary venous embolism are treated with anticoagulation. Of late, they are started on novel direct acting oral anticoagulations like rivoxabam, apixaban. But if they have antiphospholipid antibody syndrome, or if they have severe renal or liver disease, they should be started on good old warfarin. Okay, are there any questions about this? Because you have talked about this earlier. I didn't go through it in great detail, but I took you through what I thought were the important concepts. Are there any questions? Any questions? Pin drop silence. Was that too fast? Anybody has questions? Okay, I'll conclude with one slide which I have taken from my favorite most textbook, the Harrison. So if you get a patient with haemoptysis, first of all, you need to do the history and examination with two things in mind. First is to confirm it is haemoptysis, and the other one is to quantify whether there is a massive bleed or not. If there is a massive bleed, you need to protect the airway. And if the bleeding stops, you're fine, but you continue the supportive management. If the bleeding continues, you need to embolize or resect that region. If the patient has a non-massive bleed, and if you don't have any risk factors, you need to consider infections, malignancies. If there are risk factors for a bleed like a bronchiectatic cavity or a tuberculous cavity or a previous neoplasm, please also assess the blood counts, the renal function, the coagulation profile. And if you have no clues there, do a CT scan. If there is a localized region of problem, you might have a bronchoscopy in mind. You treat the underlying disease, but if the patient continues to have a bleed from that area, we might still need to embolize or resect that region. So, are there any questions you want to ask me? I am happy to answer. I took you through some concepts which I thought were very interesting for us to do. But I'm happy to answer any questions. Yes. Any questions?
Madam, I have one question. If you don't know which side if there is hemoptysis and you don't know which side of the lung has the problem, then how do you decide on the positioning?
In which case you can't really use that to position. But in reality, if there is a hemoptysis which is significant enough, there are some lung signs on that side. Or if you do an urgent inward chest x-ray and you pick it up, then you can compress the other side. If the patient is conscious and able to protect the airways, and you don't have a localizing thing, then you don't have to put them decubitus to compress the side. Did I answer your question, Upili?
Yes, madam.
Okay. Are there any other questions? There is a very poor turnout for the CLDs. Is this normal or is it just me? Yeah. Any other questions? Are there any other questions? If there are no questions, I can end the talk. Can the batch rep make sure that at least I get some feedback from the 50 people or less who are here? It's important for us to get feedback on our Zoom lectures because we don't really have any way to gauge how you respond to the lecture. So please, in the interests of your future lectures, please do give us some suggestions and email them to me. Batch rep is you, Upuli?
Yes, madam.
Can you just collect everything and just send it to me? Get
Okay.
them to email or SMS. You just compile them and send them to me. It's very important for us to get feedback. We didn't get feedback from our previous professorial group as well. We just got forms. It's important for us to improve our teaching, and we